Jennifer, please proceed.
Okay, let us humble ourselves for a prayer. God our Father, we thank you for the gift of this time. We thank you for the leaders who are going to take through this session. And we thank you for all the gifts you keep us giving. Lord, as we gather together, connected from different directions, we ask you to be in the midst of us and be the guide, be the leader, and speak through our leaders who are going to take through this session, so that whatever we are going to learn, we are going to put into actions. We ask this through Jesus Christ our Lord. Amen.
And amen. Thank you so very much, Jennifer. And good afternoon, colleagues. Once again, you all are welcome to this webinar. This webinar has been organized by the Ministry of Health to purposely raise awareness amongst us as healthcare providers, as the frontline people that are most at risk because of what we have already seen amongst our colleagues from a few of the hospitals that have already cared for people that reportedly had Ebola virus disease caused by the Bundibujo strain. So this webinar is a purpose to ensure that one, we are able to quickly recognize danger signs and be able to report them early enough through early detection and early isolation of these potential infectious patients. But then two, it also calls for us as healthcare providers to be high on alert, to raise our index of suspicion and ensure that each and every time we are dealing with any patients, we are high on our lookout to ensure that we do not put ourselves in harm's way. And in that regard, it will call for us to ensure that we are able to exercise extreme observation of infection prevention and control principles or practices to ensure that we are not exposing ourselves, but then also not exposing any other healthcare providers. And now more than ever, this is the time for us to be screening for each and every patient that is accessing our facilities to ensure that we are safe, but then also we are safeguarding the other people that are seeking care from our facilities. So with us, we have packaged a menu that is going to have the permanent secretary of the Ministry of Health speak to us at a later point in time. And then we'll also have the Director General of Health Services speaking to us. And therein, we'll also dive into the technical substance, where we'll have a team from the surveillance aspects of this response speak to us.
We have lost you. We are not hearing.
We can no longer hear.
Ingrid, could you please maybe take over the wait for Dr. Rooney to return? Ingrid? Yes, thank you so much, Dr. Sande. As we wait for our first, we can have our first presentation from the surveillance pillar, and Dr. Sande will take us through. Dr. Sande, over to you.
Thank you so much, Ampere, for this opportunity to make a presentation. Dr. Sand, I think we've lost you. Kindly unmute yourself. You can hear me now? Yes, we can. Please go ahead. Okay, let me share my slides. Just a second. You can see my slide? Yes, we can. Please go ahead. So, Chair, allow me to bring everyone to this presentation. This is the risk assessment that we did following the alert outbreak that we received. We had on 14th of May, WHO notified the outbreak of Ebola in the Ituri province in Eastern Congo. The outbreak has been confirmed in 3 health zones of Mumbweru, Rwampara, and Bunia. As of 15, 13 had been confirmed, and over 67 probable cases are under investigation. And these probable cases started as far as of 1st of April in Mungambweru Health Zone. As of now, Uganda has confirmed 2 cases that have been seeking care in Uganda and the neighboring districts. As of now, we have a multiple number of healthcare workers that have been quarantined in response to the contacts of the patients that came to seek care here in Uganda. I think this is very, very important to know that already our healthcare workers are interacting with these patients. Are we able to look at our hazard, the outbreak context, and the exposure defined by the importation? As of now, the current outbreak is caused by Ebola virus disease, Bundibugyo strain, and is transmitted through a direct close contact with the body fluids, with an incubation periods recording 2 to 21 days. It has a case fatality rate of 50% and ranges from 25 to 90. The illness is characterized by acute onset of fever with non-specific symptoms, abdominal pain, anorexia, fatigue, malaise, malaria, sore throat followed by nausea and vomiting, diarrhea, and sometimes a rash. Previous outbreak in Uganda we had in Bundibugyo in 2007 and 2008 with 149 cases and 37 deaths. You remember that also had a prominent doctor called Dr. Kule, who died during this outbreak. Apparently, there's no vaccine and no therapeutics available for this Ebola Bundibugyo. Looking at the context, the current outbreak is characterized by delays in detection, with alerts being identified following a cluster of deaths at the community level, with no evidence of safe and dignified burial conducted in the province of Ituri right now. As not in that context there's community transmission ongoing. And also at the same time, the humanitarian situations with displaced communities due to insecurity. And also we want to remember that for now, Congo has had about 17 Ebola outbreaks. They are built capacity over time. However, the current response capability is affected by operational challenges due to the humanitarian complex setting that's in that area. The economic activities with mining also results in semi-urban contexts with informal settlement, which increases the risk. In that, if we are able to find someone here in Uganda who is sick, it may be hard for us to trace that person back to Congo. And also, if someone left Congo and entered Uganda, it may be hard for them to trace that person. So with those economic activities, non-settlement, non-structured urban, it becomes the context becomes very complex. So you never know where another case is going to come in from. Look at the exposure. Uganda is a host refugee from DRC. People move for economic resources like dealing in gold and mines. And also our porous border setting makes people access our country with ease. Seeking, been expecting about 6,000 pilgrims, of which some of them came already. They are with us. And however, they will not proceed to Kampala. But we don't know what contamination they have done in areas where they have already entered. We have border points like Entebbe, where the plane comes from Bunya to Entebbe twice a week. And also have other airfields like Arua, which also brings in people from South Sudan, including also Congo. Here you look at the Mungobolo Health Zone. Allow me to use my pointer here so that I can bring it out clearly. You see that Mungobolo Health Zone here is approximately 100 to 150 kilometers from the West Nile. So these people here are able to access healthcare in Zombo, in Arua. That's why you see planes are flying from here, coming to Arua. And then from here, they use by road, they come and access healthcare services. There are some who may be coming and arriving at this place, but not proceeding to Kampala side and receiving care in these areas of West Nile. But so far, two cases have passed through. Some patients, one case that is confirmed, and those that are still under investigation are passed through this place. For the Bunya to Ntoroko is also approximately 100 kilometers. So people can pass through this place, and the nearest is using the water to this place here. So that's why you see that one of the cases was able to pass through Hoima before it proceeded to Chibuli. So you can see that this also becomes a hot zone. So those people who are unable to proceed from this area, we know they are receiving care around this area. Then from Rwampara Health Zone to Ntoroko is also at about another less than 100 kilometers. So we believe also some of these people have entered. On the surveillance aspect here, some people already left these areas of Ntoroko and went to Bare in Congo. Some of them came back to Uganda. So some of these people have been gazetted. They are now known and they are under observation using the regional EOC in Rwenzori. Some of them who have developed symptoms have been evacuated to Fort Portal. So you can see here how we are moving. Planes come from Doka to Arua. Some fly from Bunya to Arua. There's also some fly from Bunya to Kampala to Entebbe. Others come from Goma to Entebbe. And also there is also ground crossing through our major roads. And some people access our health facilities in Wera, and also those in Hoima, those in Arua, and also those around Mbarara and in Kampala, which makes it high risk. So Uganda right now here is very high risk based on the proximity, population morbidity, and reports under investigation. So you can see that these are the districts that are more at risk from northern Uganda to West Nile to western Uganda to southwestern Uganda. All those, and also Kampala being the business center is also at risk. And most of the two cases that we've had so far, they are here in Kampala. So we're requesting that everyone should be able to report these cases as they do clinical assessments. They should be able to report. They can also report through 0800-1066, or they can send 6767, or they can go to the URL of alas.health.go.ug. We'll be able to receive some of these cases here. Otherwise, that's what I can talk about here. Thank you so much. Thank you for listening. Back to you, Chair.
Thank you so much, the surveillance team, Dr. Sandy. I saw some questions in the chat asking about how many suspects and things like that. But then the next presentation, the clinical care team is going to be able to answer those questions. And if you have more questions for Dr. Sandy, you can put them in the chat, or after all the presentations, you'll be able to raise your hand and ask all the questions in regards to the presentation that he has made. Without wasting more time, let's go to the clinical care team. That is case management, and we shall have Dr. Tony Sechikongo to do a presentation for us. Briefly, Dr. Tony is a physician at Mlago National Referral Hospital, and he is our clinical care head in the Ebola treatment unit that we are having in Molago. So he is well versed with Ebola management, and he has been our clinical head since the Ebola outbreak of 2025. So he's one of the experts that you can ask all the questions where you've not understood, all the clarity, so that you help to identify signs and symptoms early enough, encourage patients to seek care early, and so that we can fight this outbreak together as healthcare workers. So over to you, Dr. Tony. Emma, you could help share the slides of Dr. Tony so that he can speak through. Thank you. Dr. Sandy, unshare your slides.
We cannot hear, Doctor.
Is it me who cannot hear anything?
I'm not hearing also.
And me, I don't get anything.
Yes, we are not hearing, please.
I'm not hearing.
Everything is not hard. We are just here watching things.
Okay. Apologies. That we have a problem with this link coming to capacity, and the presenter is having a hard time to join. But in the meantime, we can have the co-chair of the clinical care sub-pillar, Dr. Wagobera Chris, to start the presentation. And when Dr. Tony joins, he can carry on from there. Dr. Chris, over to you.
I think he can join now. The link has quite some space.
The link is 1,000. The maximum is 1,000.
It's now at 933.
Yeah, I think he's probably stuck in the waiting room. We can't see him in the waiting room, but once he's able to join, we'll be able to allow him. Yeah.
Excuse me, this is Yumbe Referral. We want to join as an EOC team, but we're having challenges here logging in.
The link is at full capacity, so we can only have a maximum of 1,000. So we've enabled a waiting room, so the presenters will allow them in. And once they're in the meeting, we'll be able to.
Yes, Dr. Wagabera Chris, could you begin the presentation?
Hello. We are really stuck. I don't know if there's a host who has the powers to admit in. We are a team from Yumberi Faro, the RRT, and we are just stuck with a good number here. Wanted to join as a group.
Dr. Tony, I can see you've joined. Please take it away. We cannot hear if someone is speaking, but Tony, we can see you already you've joined the meeting. Please, whoever is speaking, you're muted. Tony, please unmute yourself. Please unmute yourself and take it.
Okay. Thank you very much, and good afternoon, ladies and gentlemen. I hope you are hearing me loud and clear.
Yes, we can.
I hope you are hearing. Okay. So it's a pleasure to be with you this afternoon. And what we are going to talk about actually are the clinical aspects of the Bundibujo Ebola virus from the perspective of case management, clinical care team. And I'm Dr. Musoke to present it. Next slide. So I'm hoping that by the end of this presentation, we collectively will be able to understand the cause of the Bundibujo virus disease, know the mechanisms of transmission of Bundibujo virus disease and other viral hemorrhagic fevers, to identify the groups that are most at risk for the VHF infections, to understand the natural history of Bundibujo virus disease and the viral hemorrhagic fevers. We shall be able to quickly suspect and isolate Bundibujo viral disease patients and other VHF patients. Then we also need to familiarize ourselves with the discharge criteria. And lastly, list the prevention and control measures available to keep us safe as we execute our duties. So we shall begin with an overview of viral hemorrhagic fevers, and these actually include a spectrum of relatively mild to severe and life-threatening conditions that are characterized by sudden onset of fever, bleeding, shock from loss of blood and fluids. There are multiple modes of transmission for viral hemorrhagic fevers, like we are going to see below. VHFs are associated with the occurrence of major epidemics with high case fatality rates that are usually attributable to limited specific medical countermeasures such as vaccines absence and absence of antivirals or limitations in antivirals. Lack of timely laboratory diagnosis. Many times you could suspect, but then it might take you several hours or days to really get a confirmation. And by that time, an epidemic would have been driven up front. Many times we have late detection of the outbreak, then inadequate infection prevention and control practices, usually at our health facilities where we practice. And by the time we get to realize the transmission has already taken place and everybody is exposed. Then we also have those weak vector control programs, which also prolong VHF outbreaks. So the virus that we are dealing with in this particular outbreak is the Ebola Bundibujo virus, abbreviated as BDBV, or sometimes just BDV. It is one of the species of the Ebola virus that can cause human disease. It originates from the Ebola virus family, and this family has several species actually in it. Apart from that Ebola Bundibujo, we have Ebola Zaire. Sometimes when we are talking of just Ebola virus disease, we are referring to Ebola Zaire. And this was seen in the Western African outbreak in 2014 to 2016, Central Africa Republic. You realize this was discovered in 1976 near the Ebola River. And for that reason, the name stemmed from there. Then we also have another species called Ebola Sudan, SUVD. This has caused several outbreaks in Uganda. I think most of the outbreaks that we've had have been due to Ebola Sudan. Then there's, we've already mentioned the Bundibujo. We have Typhorest, which was first seen in Ivory Coast. It was also responsible for a few human infections and was able to cause disease in that population. We have the Reston. This has been observed in monkeys and pigs. It is also able to infect humans. However, no symptoms have been noted so far while it is in humans. The Bombali species is only found in bats and has not been seen to cause disease or infect humans. So going back to the Ebola Bundibujo virus, this was discovered for the first time in 2007. And in 2007, we had an outbreak in Bundibujo. That is where it was discovered. But subsequently, in 2012, it went on also caused another outbreak in the Democratic Republic of Congo. And now we are seeing it reemerge again, both in Democratic Republic of Congo and Uganda in 2026. So these viruses, the Ebola family, belong to the genus Ebola virus from the family of Filoviridae. You remember Marburg also falls under the same family. So Ebola and Marburg virus are coming from the same family. There's also another virus called Guava virus that has not been known to cause disease, but has only been identified in bats. Okay. So Ebola, the filovirus, Viridae, alongside other families that are displayed in this table here, have all been known to cause viral hemorrhagic fevers. Notably in Uganda, you realize we've had Ebola, we've had Marburg, we've had yellow fever, dengue, other parts, Crimean Congo hemorrhagic fever and the Rift Valley fever. You know what is disturbing already the Western world as we speak is the hantavirus. And then we have Lassa in parts of West Africa and parts of the Arab world. So these viruses live with us every day. Next slide. So this diagram was adapted from the CDC and tries to show where these viruses usually stay naturally. So we know that for the Ebola viruses, usually found in bats as their natural reservoirs. They don't cause disease in these bats. But once in a while, the bats get into contact with animals in the zoos and primates through maybe these animals eating part of the foods that these bats have eaten. And then they get sick with these viral diseases. And from there, further interaction with man through still the fruits that could have been eaten by these animals or the bats themselves, or man interacting with the animals as a source of food. Then we begin to see animal to human transmission, from where we begin to see human to human transmission as a predominant feature of these epidemics. So the human to human is an amplification factor. From here, we see several numbers being affected, as we shall see as we move on. Next slide. So these are the amplification mechanisms of human to human transmissions. And we know where this amplification occurs. Usually we have two arms. We have in the hospital or healthcare facilities, and then we also have in the communities. Usually disease, animal to human transmission occurs in the communities. And then we have a silent spread there, usually through families, friends, people caring for the ill, and then unsafe funeral practices when people die silently in the community there. Occasionally, we begin to see some of these patients trickle down to the healthcare facilities, like we saw for this particular Uganda outbreak, where you see one patient coming and has been sick in the community, comes to the hospital, is admitted, and then for some reason, healthcare workers are not guarding themselves already. So we begin to see infections taking place in amongst healthcare workers and other patients that could have been admitted with this patient in the hospital. Occasionally, we also get transmission of these viruses through unsafe injection practices. Usually, the risk factor and the major driver for these infections, inadequate infection prevention and control practices, both within the communities and in our healthcare facilities. Next slide. So several modes of exposure or transmission to humans exist. In the humans, whether we are in the healthcare setting or we are in the communities, we usually get contact through blood, secretions, body fluids, and organs of infected animals including birds and other animals. Then secondarily, still through blood, secretions, body fluids, and contaminated surfaces. So you don't need to have really an animal or a person present at that particular point in time for you to get infected. Even just getting in touch with contaminated surfaces or materials in an adequate enough dose is sufficient to get a person exposed and subsequently infected. Next slide. So once somebody has been exposed, they don't develop symptoms immediately. It takes some time as the infectious agent moves from the area of exposure to the bloodstream and then starts to multiply. So at the end of a critical mass, if a critical mass has been achieved, then we shall begin to see symptoms developing. So that period between exposure to the time when somebody starts to experience symptoms, we refer to it as the incubation period. For this particular virus we are dealing with, the Bundibugyo virus, the incubation period usually stretches from 2 days after exposure to 21 days. So that means anybody can develop infections after exposure just 2 days, or infections may delay. Okay? Infections may delay based on no?
We can hear you, please go ahead.
Okay, sorry. That infections might actually be delayed based on different aspects of the patient's immunity and the infectious dose and several other factors. I seem not to be seeing my slides here. I don't know, can somebody project and we see?
Emmanuel, could you maybe stop sharing and reshare?
Okay. Yes, can we go back to the previous slide? I was trying to stress that up to 21 days, still somebody is capable of developing symptoms. So for that reason, it is very, very important to have all exposed individuals monitored for at least 21 days for symptom development. And during this point in time, these individuals should always make an extra effort to keep away, to do self-isolation. Okay? We know humans are not infectious until they develop symptoms, but you never know when these symptoms are going to come, and you don't want them to come when you're near other individuals who are not exposed, because they will then also be counted as exposed individuals. So it is very important to always monitor for these symptoms and self-isolate or go into quarantine to wait until the 21 days are over. Next slide. So once we finish the incubation period, there are two possible outcomes. Either the infection does not take, and therefore you'll get out no symptoms, no disease. We have seen another possibility where you can have a silent or a subclinical infection, and then people get better afterwards. But also, the other outcome is the patient usually develops, the contact usually develops symptoms. And these symptoms usually have an order in which they will present, depending on the number of days from start of symptomatology. So the early symptoms can include fever, symptoms like fever, severe headache, muscle pains. You'll find the patient so tired with extreme fatigue. You'll have reddening of the eyes and conjunctival injection. Okay. Once in a while, you might have diarrhea, loose motions, but mild, and vomiting mild with nausea. So the GI symptoms are not very common in this phase of symptoms. But as the days progress, usually going past 4 days, then we begin to see other symptoms coming in and with more severity. So we can have severe sore throats coming in, you can have chest pain, abdominal pain, then you have diarrhea and vomiting. And these GI symptoms, including hiccups, epigastric pains, they're severe and usually lead to complications if not checked at that point in time. Then as we proceed, then we begin to see really late symptoms coming in. Like many times when we talk of viral hemorrhagic fevers, many of us, the first thing we think about is bleeding. Many times, if you wait to see bleeding, then you're going to have a risk of exposure because this is a very late sign, very late sign or symptom coming in. We see bleeding in just about maybe 30% of the individuals. And even then, when it comes, it is a very late sign. And it is a poor prognostic factor. Then we have issues like skin rash, people getting into respiratory distress, shock, multi-organ failure, and then other complications like coma and seizures. Usually, for individuals who survive the viral infections, they may not develop so many of these late clinical signs and symptoms. Then those who go on to have these late clinical signs and symptoms, it's usually associated with a very poor prognosis. The only chance we have to prevent them from going into these late signs and symptoms is if we start management of these patients early. On the side of labs, we have seen in the early phases, usually electrolytes are not so much disturbed, but you may occasionally see hypokalemia, hyponatremia, usually as a result of excessive vomiting, or some vomiting and reduced appetite, okay? You can see magnesium down and then patients get into acidosis for the same reasons. But as the diseases progress, then we begin to see more cellular damage, multi-organ damage, and the organs begin to fail. And then we see issues like urea and creatinine actually going up for several reasons. You can see lactic acidosis. You may see hyperkalemia or hypokalemia, depending on which is worse. Is it the cellular damage, or depending on whether somebody is having excessive vomiting and diarrhea? So the excessive vomiting and diarrhea, fluid loss will lead us with a hypos. whereas excessive tissue damage will leave us with the hyperkalemia. Of course, so is the magnesium and the bicarb. We see derangements in liver function tests, usually as a result of virus damage to the liver, reduced glucose levels, reduced because patient is not eating, and then increased PTT and INR. Usually, if patient improves before maybe 9th day, yes, chances are also high. Otherwise, if these complications, the late complications set in, then we begin to see increased case fatality rate in these patients. Can we move on? So this was just supposed to take us through what happens in the body, because your body is also just not taking it seated down. You see that early after the incubation period, when the symptoms set up, or just shortly before that, you begin to see the virus multiply now. And that is what brings on the first symptoms and signs. So it multiplies until around maybe day 5, day 6, day 7. And then there is a delayed response usually by your body, where we get to see the antibodies start maybe on day 3, day 4 to also rise. And when they have risen significantly, then we begin to see them controlling the viral load, which will start to fall down. The curve falls down up to maybe day 28 onwards, when we shall check possibly, and we shall not have virus detectable in the blood. So this is very important for us to know that for people with reduced ability actually to mount a cell-mediated immunity, you might have the virus prolonged for a particularly longer time, and damage to the organs and tissue might actually be prolonged, leading to those other complications, the late complications. Whereas people who develop the immunity a bit early also are able to control the virus early, and then recovery is improved. And I think this is part of the principles applied when we use early vaccination when we get exposed in disease. Okay, can we move on? So how do you make a diagnosis? Because you don't just look at somebody and then you say this person has Ebola or not. Many times you might be judging the patient wrongly, and you end up denying the patient useful treatment that would have been life-saving. Or sometimes if you actually don't have think about the possibility of viral hemorrhagic fever, then you might hurry, treat a patient, neglect your protection, and then you end up actually exposed to disease, and you become part of the chains of transmission of disease. So it's always important to have a high index of suspicion for not only those patients when the outbreak is there, both in and outside the patient. Actually, I mean outside the outbreak. So it should be for every patient coming your way as a healthcare worker. You should always have a high index of suspicion. In case you see anything suggestive, probe further, and then get to have the facts clear before we get into problems. So you're supposed to take a good detailed history. You're supposed to take note of the patient's symptoms. Are they suggestive or are they not suggestive? When we are out of the epidemic times, it might be difficult for you to really find an epidemiological link. Otherwise, if there is any place where you know there is an outbreak, it's always good to try to get to know the travel history of the patient, okay? And whether he has come to contact with any patient with similar symptoms, whether at home, in a taxi mode of transport, okay? And then also when you see a patient who you are treating and 15 hours. He's not responding to treatment, I think you always have to go back and explore what could you have missed in this patient, okay? So like in our patient this time around, he went to the hospital, the first hospital, and the first hospital treated PUD, treated, I think, malaria and that. But then because the patient was not improving, they did not think, because earlier on we know that the outbreak in Congo had been announced several days back. They did not think of asking whether the patient had had any contacts or any travel history, okay? So instead, patient got referred to another hospital. And that is how we now begin to amplify the chains of transmission. Next slide. So when we are in an outbreak, after you've had your good history taking, you suspected the patient, then you're supposed to ask yourself several questions, okay? And these amount to a case definition. So when we're in an outbreak, if a person has any history of contact with a fever or contact with any one or more signs and symptoms, that one is a suspect. If we have any patient who has a fever during an outbreak with 3 or more signs and symptoms that are suggestive of a viral hemorrhagic disease, then that patient should be taken as a suspect. Then the next 2 possibilities are when somebody dies and you can't explain why that person has died, or a person is bleeding and you can't explain why this person is bleeding. The issue here is you cannot explain, okay? So cannot explain is different at different levels of healthcare settings. Cannot explain in a national referral hospital, I expect it to be at a higher level, and cannot explain in a health center 2, 3, and sometimes health center 4, may it actually have a different bearing. But whenever you are unable to explain bleeding, you are unable to explain death, then suspect this patient for hemorrhagic fever. And once you suspected, then you should take off blood or call the team that takes off the blood, the surveillance team, so that we can have this blood checked. And once we get a positive result, then we say the patient is confirmed to be having viral hemorrhagic fever. You must note, however, sometimes you take to check for these viral hemorrhagic fevers and they are negative if the patient has been sick for a few days. So under some such circumstances, you are supposed to skip another 2 days and then take off the test again, because by then we believe the patient will have been symptomatic long enough for the virus to be detected. Yeah. Now you realize once you suspect this patient, you need to isolate for the safety of the other patients and the safety of your own colleagues and yourself. And once you don't have a good isolation space, then we should advise that you should take that patient, should ask the surveillance team to come and have this patient taken to the nearest isolation or treatment center until we're able to prove that this patient maybe is not infected with viral hemorrhagic fever, and then he can be safely returned for further care in your facility. Next slide. So many times, this viral hemorrhagic fever, including our Bundibugyo virus disease, presents with symptoms that are very common in everyday patient care. And for many reasons, we intend to mistake these viral hemorrhagic fevers for the common conditions that we commonly see in the hospitals or healthcare facilities. Notably amongst these is malaria, typhoid fever, shigellosis, and so on and so forth. Sometimes even cholera, depending on what symptoms that the patient is going to present with. It's not bad to think of them, but once patient, even if he has these conditions and not the viral hemorrhagic fever, the moment he's meeting the case definition, it is very important that you have this patient also checked for the viral hemorrhagic fever, because we can still have co-infection. You can still have a person with malaria get viral hemorrhagic fever exposure, and so is all the other conditions. Okay, so I thought this slide I need to put it so that we know that yes, it doesn't come alone clear cut as a viral hemorrhagic fever, but you can still have it coexist. And indeed, whenever we are in the treatment centers, we also check for several of these conditions. Some of them we rule them out clinically, but those that we can check by the bedside, we do check to ensure that we don't lose patients, not because of the viral hemorrhagic fevers, but because of the other comorbidities that we could have neglected to look at. Okay. All right, can we continue? So patients, we've made our diagnosis. How do we handle these patients? I will not forget, or I'll get tired of reminding us all that we should always observe our IPC protocols. In IPC protocols, we have those that are standard and then the universal protocols. And these have been established to protect us, okay, in the communities and the areas where we work. So please, whether we are in an outbreak or within the outbreak itself, we should not forget the standard and the universal IPC standard protocols, because they keep us safe. In several outbreaks, actually, many people confess, many frontline healthcare workers, that what saved them was because they were observing the IPC protocols. So somebody knows that before touching a patient, after touching a patient, before this, actually the 5 moments of hand hygiene, they are well observed for each of us healthcare workers, okay? You need to have gloves before you touch a patient. And in between patients, please change the gloves, wash your hands. I don't know how many of us healthcare workers remember to do this, okay? So that way, we don't transfer infection from one patient to another, or infections from the patient to ourselves, or ourselves to the patients for that matter. It's always important that we observe these protocols. Then once you've finished protecting yourself, which I should also say, you should always be selfish. It is your safety first. Then after you've protected yourself, make sure all the patients coming your way are sorted out. Primarily, we sort them out to we screen. We call it screening. You want to separate those who are likely to be having viral hemorrhagic fevers to go on one side, and those who are unlikely, they don't meet the case definition, to be allowed through so that we can have them go for treatment. Okay. So screen all those patients, and then those that are suspects, you take them through the process we have identified. It's important that you isolate promptly, arrange transfers where necessary to volumes that have, to areas that have isolation units. Then for you, the healthcare workers, should you find yourself exposed, I repeat again, please do self-isolation for your own safety and for the safety of your family, the safety of your loved ones and your mates. Okay, and report your exposure, and then we can see what to do afterwards. Next slide. Okay. So the response usually relies on large interventions and public health measures that will need to be thoroughly implemented. While we are in the ETU, we give supportive care, which is usually following the optimized supportive care guidelines for VHFs. We do early detection, adequate IPC, as we've been mentioning, rigorous contact tracing, safe barriers, and then community engagement. It's also important to know that for this particular virus that we're dealing with this time around, there is no licensed vaccine or specific therapeutics against it. So we shall depend mostly on the supportive care and those other enlisted interventions. Research has been started and it's ongoing. Okay, so we shall wait for that. Next slide. Okay, this is showing you the VHF therapeutics. And to show you that Ebola, most notorious, we've had Sudan, Ebola Zaire, which you see as above. Then Ebola Bondibujo is amongst the others, for which you can see there is no approved therapeutics, okay? And there is no vaccine. That's what I wanted to put out for that slide. Next slide. Now, remember we mentioned the last two Bundibujo outbreaks, one in Bundibujo in 2007 in Uganda, and another one's DRC, 2012. And for those, we've had case fatality rates ranging from 30% to 50%. It's a very deadly disease. Yeah, it's also important to note that people remain infectious as long as their blood and body fluids contain the virus. So for that reason, we tend to keep them until we cannot detect the virus in the blood, and then we continue to monitor them until their body fluids are free of the virus. Next slide. So once we finish the treatment in the treatment unit, then we have a number of criteria to follow before we discharge. Mentioning this so that we don't get so scared of patients when time comes for them to transfer maybe from the treatment unit to their communities, or sometimes for other conditions that they could be having, comorbid conditions, we might need to take them to the hospital for continued care. Many times we send the patients there, and then the healthcare workers neglect the patients instead, and yet we think the patients are safe. So how do we go about discharge? One is the patient should have had more than 3 days without fever or any significant symptoms for that matter. So asymptomatic for 3 days. That is criterion number 1. Then number 2, clinically, you should see that the patient, the condition has improved. Okay. Then 3 is able to do activities of daily living. You see, he's sometimes taking himself to the bathroom, is able to dress himself, And then lastly, we go now, once he has met those 3 criteria, we go for the last criteria where we do a PCR test. And once that PCR comes out once and is negative, then we are sure this patient is safe to rejoin the community. You must note sometimes even after all these other 3 criteria are fulfilled, you might test a patient and the patient is still positive. So we shall still retain such patients. We retain these patients and we do serial PCRs every after 2 days. So once the PCR finally turns negative, then we shall allow this patient to join, to go back to the community. Next slide. These are a few issues to note for our patients that we might go back to the community. But remember, we said some of the body fluids might still contain either the virus or virus particles. Okay. Notably, for men, the virus may stay in the semen. So far, we've noted up to 18.5 months in the EVD survivors, but still the particles can go on up to 2 years. So for that reason, we do surveillance of the semen monthly, okay? And we do their PCR on the semen, and we only stop that if the patients have, the survivor has been negative twice, okay? On 2 consecutive PCRs. And during that time, we usually cancel for safer sex practices, or if they can't abstain, then we always advise on barrier methods. Then to note in women survivors, usually there is a higher chance of miscarriage and fetal death. You know that a pregnant survivor with VHF who has a miscarriage is a suspect. So the moment somebody has been survived the VHF and gets a miscarriage, please, that is a suspect. You need to really be protected to handle that person. Okay, so you therefore refer to an infectious diseases unit for further handling until PCR is negative. You also counsel on safe sex practices and barrier methods. You should note that sometimes the breast milk can also stay positive. You also do what we did with the semen in the men. You're supposed to check every after 48 hours, that's 2 days, until they turn negative. Next slide. Okay, so that was my short presentation for you this evening. Thank you very much for listening to me.
Indeed, short and very long. Thank you so very much, Dr. Ssekikongo. Very grateful and very insightful. Colleagues, we will request that you keep your questions and clarifications by just noting them. And at the end of it all, we will have a question and answer session where each one of us will be given an opportunity to ask questions. And Dr. Ssekikongo, you've done a very great job. That's the reason why you're seeing everyone clapping out for you. Thank you so very much. So colleagues, our next presentation is on infection prevention and control, and it's going to be presented in 2 parts. We'll have Dr. Elizabeth Katwesje, the IPC specialist at the Ministry of Health, taking lead on introducing the subject, and we will have Dr. Maureen Mthide diving deeper into the implications for a healthcare provider on how to respond to patients presenting with signs and symptoms consistent with Ebola. Ebola. Elizabeth, you have the floor.
Thank you very much, Chair. Good afternoon, colleagues. Kindly confirm you can hear me. Can I be heard?
Yeah, audible.
All right, thank you very much. The previous presenter has given some briefs about the precautions to take while caring for patients. We shall just have a deeper dive in some of the key aspects. And I'll just begin by highlighting that the structure of the virus, this is an enveloped virus, and this predisposes it to be easily destroyed by soap, chlorine, and the open environment in the air and the light, which makes it very easy for the IPC precautions we're implementing, as simple as they sound, to be able to destroy this virus. Regarding the transmission, this has been mentioned earlier on, just to emphasize the direct contact between infected human beings, but also the exposure to contaminated surfaces and patient care equipment and other belongings that were used by an infected person, which really emphasizes the need for us to be able to perform IPC precautions that look at cleaning the environments, but also the equipment we're using, reusable materials, both patient care, but also in the healthcare setting, including linen and others. For the signs and symptoms, Dr. Tony has highlighted this very well. From the IPC perspective, is for us to take note that the initial symptoms, as have been highlighted, the fevers, body weakness, the headache, are really non-specific symptoms that can present with any other conditions, like has been mentioned by Dr. Tony. And hence, for us as healthcare workers, the emphasis is to have a high index of suspicion, to ensure that we screen both outpatients, but also patients who are already on the ward being treated for other conditions, to continuously apply the case definition so that you easily detect suspects, and then you do a risk assessment for all the procedures you're going to do with the patient to guide the precautions you're going to take to ensure that we have both safety during care, but continuity of essential healthcare services, because patients will continue coming to the facility. So we have to be able to assess them properly, assess the procedure you're going to do and the risk it's likely to expose you as a healthcare worker, so that you choose the right sort of precautions, the PPEs, and the other IPC precautions that will be highlighted in the subsequent slides. The main measures for infection prevention and control are in these different 4 sections, the identification. And after identification, we have to be able to isolate them in a safe space away from others, and then notify so that the patients can now be managed accordingly. And then we do have the standard precautions that we've always talked about. And these include hand hygiene, appropriate use of the personal protective equipment, injection safety, sharps injury, the safe waste management, proper management and decontamination of the patient environment, the linen and the patient care equipment, respiratory hygiene, and most importantly, risk assessment for every procedure we are going to do, whether it's an emergency or it's a routine procedure, to take a step and ask ourselves, what am I going to do? What is my risk of exposure to body fluids? So that you can select the right sort of precautions based on the anticipation of exposure to the body fluids with the patient you're caring for. And then the transmission-based precautions, where we have the standard that have been highlighted above, which should be for each and every patient, with risk assessment on what additional precautions will you have to ensure that you don't get exposed to Ebola. And this will be highlighted in the subsequent presentation. And then we do have the engineering controls and administrative measures. What can we do with the spaces we have in the facility to minimize the risk of infection? And all these are really aimed at breaking the chain of transmission, looking at what is the possibility of the infectious agent moving from where it is, the reservoir, an infected patient, an infected surface, how is it transmitted to the next patient, and anything we can do along this chain really will minimize the chance of transmission of the infection. This highlights the hierarchy of the controls. We see the bigger part of the triangle is up there. These are the measures that really we should have most of the emphasis on. And if it was possible, would eliminate, and some of the measures we're putting in place to eliminate the hazard in our healthcare facility. Things like screening to ensure that if you have a suspected patient, then we put them aside and we don't allow them to first move through all the wards, and we discover it like on the 4th day when they've exposed many more people. We have to reduce the entry points, the facilities, ensuring that the facility entry is controlled. We have a fence, we have security at the entrance, because that's the only way you're able to effectively screen. Otherwise, if you have attendants and patients entering from multiple points, you're not able to minimize this. Reducing the number of visitors. By standards, we should not have overcrowding in the wards, and reducing the number of visitors, really ensuring you have strict visiting hours, but also having less visitors to the patients, so that you minimize on the number of people in the ward that can either bring in the infection or contaminate the other patients. The second is finding alternative ways of providing care. Our colleague from the next presentation will talk more about this, looking at those models, especially in the high volume facilities. What can we do for the chronic care patients? Maybe we give them multi-dose dispensing so they don't have to come back so frequently. What care can we offer outside the facility? Telemedicine, so that we are able to minimize on the number of patients coming in. Then the engineering controls, isolation, having physical barriers, restricting movement within the patient care area, following the proper patient flows that have been identified and set up by the facility, including how to move from the entrance, the triage, to the wards, having clear patient ways and restriction of movement to other areas, for example, the isolation. And then some administrative controls, ensuring that we have our SOPs. The SOPs are available. We'll be sharing them through after the presentation. The healthcare workers are oriented on these SOPs at our facilities, including the support staff, our cleaners, the waste handlers, and the like. And using personal protective equipment, which is the level that gives you the least protection if you use it without the above levels. And this is guided by risk assessment for each procedure that we're going to do. You do realize that many patients or visitors will visit our healthcare facility even during the outbreak. Some of them may have Ebola symptoms, some of them may have Ebola, others will come for the essential health services. And we need to protect ourselves through screening. We are re-emphasizing this because this is what will limit the infection being introduced into the healthcare facility. Then once we identify a suspect, we have to isolate them in a designated area, and then we notify so that the patient is either taken to a designated facility or more guidance is given on how to manage the patient in the meantime. The screenings really is for us to use the case definitions through the screening algorithm, and it's done at a distance commonly, non-contact. We encourage utilizing the non-contact thermometers and asking the questions according to the questionnaire, and it does not commonly require close contact. However, if a patient is very unwell, it may require close contact, which means you need to put on the PPE for close contact with the patients. Following this, we need to triage the patients to be able to assess the severity so that we can prioritize the care for the urgent patients vis-a-vis the patients that can wait. And we already have the Ministry of Health triage tools that can be used to do this. Then finally, like I mentioned, we need to be able to separate these patients to reduce the risk of contact. And guiding the patients to isolation may require physical or close contact, hence the healthcare workers will have to put on the PPE. Screening is for all individuals entering the healthcare facility, whether you're visitors, healthcare workers, and patients. And the best place to have this is at the entrance before we have the patients getting into the healthcare system. And like I mentioned, the case definition is utilized, and the setup is as the picture is highlighted here. You can have a table, but also you can have an umbrella in the middle. You can have a physical barrier using plexiglass. What we're encouraging is that you ensure that we have a physical object between the screener and the patient to be able to minimize a risk of the patient crossing over to the other side as you're screening. This is the general setup. We have a green area where the healthcare workers will be on the left. Then we have the patient zone. We need to have at least 1 meter distance, like I've highlighted, but also important to provide a waiting space that is well with physical distancing of the patient so that you don't have everyone crowded at the gate, so that you can screen them. Even as they're waiting, there should be that screening. And efforts to provide a dedicated toilet if possible at this point. Just to highlight, to give guidance, the healthcare workers need to give guidance to the teams that are screening so that the thermometer is calibrated, but also what temperature are we recording? Because sometimes you go to a screening point and someone is taking all these temperatures and noting them, but they don't know when to call the health to call for action. So ensuring that this guidance is given, changing the batteries frequently. If we're taking temperatures less than 35, we definitely know that the thermometer is not working. So recalibrating it and putting the cells so that we're actually screening. And once you've been able to screen their patients who will enter the healthcare facility for routine services, or the patients who have no symptoms and no exposures. However, for the patients that have the symptoms as per the case definition, they have no symptoms, but they have exposures. These ones need to be put in touch with the contact tracing team so that we're able to follow up more on those. And the ones that have the symptoms and the exposures who meet the case definition will be guided to either the isolation space or the holding area, depending on the level of the healthcare facility where they've presented. During screening, if you're able to maintain the 1 meter distance as we've highlighted, you do not require PPE because you're not getting into contact with the patients. However, if you are unable to maintain that distance, for example, you need to help a patient who is very sick, you need to be able to put on gloves, medical mask, and eye protection, either with a face shield or a goggle and a gown as highlighted here. And the SOP that has the details of how to put on the PPE will be shared. And then for isolation, each healthcare facility, especially the hospitals and above level, should really have space identified within the space we have that can safely keep a patient and receive health care. In the meantime, as we're doing further investigations, this should be separated from the other patients and only utilized for the suspected patients with clear signage and a dedicated toilet. If it's not possible, we use a commodity so that the patient is not using the other general toilets and bathrooms, exposing other patients. And the equipment that is used in this area should not be shared with other parts of the facility. So we need to be able to identify a few equipments that are utilized for patient care, and we keep them in this space. Isolation doesn't mean that we just put the patient there to keep them, but we also have to offer them care as we are waiting the next step. Setting up isolation, the guidance is that we have 2 zones that are well demarcated. One is the green zone, which appears on the left in green, which has the healthcare worker related activities. We have our office, our planning, our healthcare worker resting and changing area so that they are able to put on the PPE and cross into the area where we are treating the patients, the suspected patients, which is the red zone, and are able to transition out of that area after removing the PPE and coming back to the green zone to rest and to make patients notes and the others. What is very key for us is that this area should really be well demarcated, but also physical protection to avoid patients from crossing over, having dedicated equipment as I've highlighted, but also ensuring that there's some sort of security to ensure that the patients do not move away as we are waiting either transfer or referral to the next level. These are just examples of the spaces we can have. Like I did highlight at the high-level facilities, having space with the beds and other patient equipment, but at the lower-level facilities where it may not be possible to have this, just having that area where the patient will wait safely as we await evacuation, so that the patient doesn't get bored and go to look for tea or it's in the sunshine and they go to look for rest and other things. The PPE that is utilized in the isolation area, we have to put on coverall, the surgical gloves, the rubber boots, the eye protection, and this is what we've commonly been referring to as the full PPE, the PPE that we're going to use to manage the patients. For any reason you're going to get into close contact with the patient, you must put on this PPE. If you do not have this PPE, then in the meantime, you'll offer care at a distance. But as a facility, we should be putting measures in place to ensure that we get the components of these patients who require care, even ahead of evacuation or referral to another facility, depending on the guidance at the moment. I will not go through notification. Dr. Sunday talked about this, but notification is very key to notify your supervisor, notify at the higher level so that the patients, you get more guidance on how to manage the patients. Just for emphasis on the PPE items, risk stratification is very key. We are not going to put on the same level of PPE for all the activities because we might come into contact with an Ebola patient. But like has been highlighted, we need to keep the standard precautions and do a risk assessment. If we have a suspect patient or confirmed patient with Ebola, and we're going to get into physical contact with them, patient bathing, patient care, we need to put on the PPE items that I've highlighted, the double gloves, the facial protection, the mask, the coverall, disposable aprons, and gumboots. And then for the dead body management and other physical activities like cleaning and decontamination, on top of the above, we need to add heavy-duty gloves and heavy-duty aprons to minimize tears in our gloves as we're manipulating or cleaning. The principles of the PPE is that we need the healthcare workers to really undergo training and simulation because this is a motor skill that can be, especially the Ebola level PPE, that we can master only if we do it. So let's have some demonstrations in the facilities. We do have some videos that can be shared, but also as we are going on, we have ongoing trainings and orientations. But let's be able to look at the SOPs and practice how to utilize the PPE, but also avoid utilizing the PPE and still putting yourself at risk. For example, by you're in full PPE, but you're touching your phone, you're not removing the PPE properly, you're touching your face, those kinds of activities will still put you at risk, even when you're putting on the PPE. This is just highlighting how the SOPs look like, and the Secretariat will be able to share through the folder with all these SOPs for more reading. Emphasis to the obstetric departments because of, and other surgical areas because of the high exposure of fluid, splashes and alike. Just to emphasize that the standard PPE for deliveries should be maintained. And this includes the facial protection, the long-sleeved gowns, and the rubber boots. For the patients that are pregnant, but also EVD, Ebola suspects or recoveries, like Tony has mentioned, may still be at risk. The PPE utilized here is the full PPE like we're utilizing for routine patients, for the care of patients that have Ebola. Just run through briefly the other standard precautions. The hand hygiene remains with the 3 options. The 2 are the ones that are mainly recommended: washing with soap and water when hands are visibly soiled, or disinfecting with alcohol-based hand rub of 70% and above concentration. However, if soap and water or the alcohol-based hand rub are not available, we can utilize chlorine of 0.05%, but this is the inferior measure because it can predispose to cracks or abrasions in the hands, which then predisposes to wounds and risk for infection. The hand hygiene follows the 5 moments of hand hygiene, like we have always highlighted. Ensure that you look at the SOPs and remind yourself to protect yourself from acquiring the infection, like the previous speaker mentioned, but also to protect the patients that you're seeing. Do hand hygiene before contact with the patients, but also after contact, before moving on to the next patient, after contact with the patient's environment, after contact with body fluids, and then before touching the next patient, so that we minimize both transmission to ourselves as a healthcare worker, but also transmission to other patients. Of course, this requires that we have the alcohol-based hand rub at the point of care, and we have soap and water available in the wards, the screening points, and alike, to encourage healthcare workers and patients to also wash their hands. Please follow the steps. Let us not just wet the hands. Follow the steps for hand rub and hand washing. I'm sure these posters are available with us so that you potentially cover each area of the hand that would be contaminated to ensure your hands are safely clean. For the sharp objects, emphasis is on do not recap needles. Discard the needles immediately, and the sharps box should be at the point of care. next to the patient while you're doing the procedure as much as possible. Don't leave the sharps in other areas that are not the sharps box, and always close the sharps box when it's 3/4 full and dispose it away. But also education for the handlers of the waste. I will not take a lot of time on cleaning and disinfection, but just to highlight that we need to clean with soap and water before we disinfect. We are not going to power the disinfectant on the environment that is contaminated, because then this will disinhibit the disinfectant. And we need to put on the PPE that has been highlighted so that the healthcare worker or the hygienists feel safe to actually handle the materials and clean according to the procedures that are highlighted here. Also to note that we are not spraying the disinfectant, but rather following the steps, utilizing a mop and buckets to minimize on healthcare worker adverse events that have been observed from the spraying, but also to ensure that we have enough contact time for the disinfectant on whatever we are disinfecting. The waste management, as we've always done, is to segregate the waste according to the types, the domestic, the infectious, and the infectious includes the red bin waste and the sharps container. But just to note that all the waste from the Ebola treatment or isolation units or any other activities that are related to Ebola, including burial, cleaning, and others, is considered infectious and should be managed as infectious waste, whether it's from patient remains of patient care, eats, and others, is considered infectious. Then briefly, for safe and dignified burials, the IPC precautions are very key because the bodies are highly infectious, and the precautions for handling the body, including the body bag and how to transport it, are highlighted in the SOP. Just to highlight emphasis on ensuring that the burials are dignified, not just the safety part, working with the local teams, the religious leaders, and others as per the SOPs, but also community education about the dead bodies and the dead body handling and manipulation. As I come to the end, there are some other procedures that are very key that we would like to put more emphasis in. One is inpatient surveillance during the outbreak. We do have patients that will be on the ward for very many other reasons, but could have had exposure to the hospital and came to the hospital during this period, the incubation period, and can potentially develop symptoms while on the ward. And that calls us, the clinicians, the healthcare workers, to ensure that routinely we are observing the patient's emphasis on the case definition, even when I've come in with another reason that may not be related to Ebola, because I can get exposed in the hospital, I can have got exposed and I'm still in incubation period. So being able to take temperatures at least twice daily, look out for the other symptoms in the case definition, and looking at best ways on how we can document this so that we're able to follow up even in the different shifts that come in the ward. Of course, utilizing the standard precautions as we care for the patients. The other key area is we need to have systems in place to identify healthcare workers who have had a potential exposure, so that we have a better understanding of the lapses in the IPC practices, and we use these for improvement to prevent further exposure, but also for these healthcare workers to be followed up on by the contact tracing team to minimize the risk of these fellow healthcare workers exposing us, because commonly in the hospital, we're in common spaces at lunchtime in the different areas. And we do have a risk assessment tool that is also included in the tools that we utilize that will guide us to assess what possible exposures could have happened and what are the mitigation measures we can put. That just to encourage our leadership, our IPC focal persons, to encourage the healthcare workers to self-report, but also create an environment that is non-punitive so that they are able to come out and report. Then we have the IPC ring approach, which looks at mobilizing teams to be able to assist the areas that are affected by a positive case, both the healthcare facilities, the households, and the communities, quickly to ensure that we minimize the spread. And the picture just showed we have a case of EVD. Of course, they've been at their home, they visited the health facility and the community, and our role as IPCs to ensure that we come in and decontaminate the areas where the patient has come through, increase the detection through screening, look at healthcare workers that manage the patients to assess for exposure risks and any breaches in PPE, in other IPC practices, and really reinforce the IPC standards. And this looks at mapping the areas where the facility has been and utilizing the resources. We have to prioritize what should be done in the different areas in a timely manner so that we minimize the spread of the infection. And then at our healthcare facilities, we need to be able to do a rapid IPC WASH assessment. We've already been doing these assessments, but just going back to have that quick eye of what are the key areas that we need to actually improve based on a standardized tool. And there is a tool that gives those key indicators that can be assessed. And it also gives guidance on the actions that can be taken quickly to ensure that we are more ready than usual if we get a patient that has a highly infectious disease like Ebola. As I summarize, screening is very key. Isolation, notification, offering minimal care. If you're not able to have the extended PPEs that are required before entering isolation. And then notification, getting guidance on how to transfer the patient. And once the patient has moved, to be able to use the appropriate PPE to clean the area, but also dispose of the waste safely, because all these are points where waste infection can transmit. As I come to the end of the presentation, as a take home, really, we need to look at the screening and isolation protocols and we implement this. The standard precautions have been highlighted. Always have a risk assessment as a healthcare worker for each activity that you're going to do. What is the risk of exposure to body fluids? And what can I use to minimize that risk? That's what will guide if you need facial protection, if you need gloves, if you need the full PPE. Proper environmental cleaning, disinfection of the materials we're using in patient care, training of the healthcare workers, including emphasis is put on the support staff who are really helping us with some of the high-risk areas like cleaning, like waste management, and then monitoring and supervision of the healthcare workers to really ensure that we are implementing the IPC standards, and finally supporting the community settings to ensure that even in the congregate settings in the community, we've set up our hand hygiene stations, there's information going on infection prevention and control, and working with the other pillars really for community engagement and social mobilization to mitigate the ongoing transmission. The key references and resources are highlighted here, and these will be shared with the webinar materials for members to utilize. Thank you very much. Back to you, Chair.
Thank you so very much, Dr. Katwesi Jeff, for that elaborate presentation on infection prevention and control. Colleagues, we have a national infection prevention and control guideline that is available with us. It's available online. Feel free to use it.
Thank you for viewing.
Feel free to consult with it so that we can be guided on how to keep ourselves safe and how to keep the how to keep the patients that come to us safe. Without losing much time, I'm going to invite Dr. Maureen Amthire, who is going to run us through how to care for patients within a hospital setting without necessarily exposing yourself, and how to tell apart malaria from Ebola signs and symptoms. Maureen, you have the floor.
Thank you very much, Commissioner. Thank you very much, the previous speakers. They have really made my work simple, and I will quickly move into the guidance for continuity of essential health services during the public health emergencies. And to note, like we've been saying, we need to really increase our index of suspicion. The patients that come to our wards are not labeled and are not labeled malaria, are not labeled the infection. Most of these come through just with a fever and the different symptoms. Just a minute, I see my slides are not moving. Sure. Okay, like we've mentioned, really the public health emergencies increase the demand of health services notably areas where we have challenges of patients that have been identified with Ebola. We have reduced access to facility. We have increased need for emergency care. We have some changes that happen within the health workforce where we have shortage. Like currently, we have a number of health workers in quarantine, and this brings in a strange, really, on the supply chain of essential medicines and diversions of some of these supplies. So over time, with the different public health emergencies, we've noticed that it's very important to anticipate these disruptions, but also mitigate them so that we do not have excess morbidity as well as mortality from the other routine health problems. So it's very important that as we respond to Ebola, we are also keeping an eye on the other diseases that are happening within our facilities. We have several mortalities happening as a result of severe malaria, but also to note that we have the measles outbreak in certain parts of the country. So it's important for us to ensure that as we respond to Ebola, we are also keeping an eye on the other morbidities that come within the facility so that we do not lose more numbers from this other routine, but also as patients shun the facilities, utilizing the community. So this is really the basis as to why it's very key that we keep an eye and focus as well on the other routine services as we look at response to Ebola. These have already been mentioned, the signs and symptoms and the different incubation period the patient can present at any one time during that time, during the incubation period. But also important to note that like the clinician really already presented, hemorrhage is seen almost in less than 40%. So these different differential diagnoses are very key for us to keep note of, since the signs and symptoms are usually non-specific and making the diagnosis quite different. We've already seen the response strategy, and here I am just presenting the component of continuity of essential services. And the objectives really of this is to ensure that we strengthen governance and coordination mechanisms for provision of these services, both at the national as well as the subnational level. But also to provide guidance on a set of immediate actions to reorganize and improve access to these essential health services, avoiding unnecessary deaths. And the third objective is really to monitor the continuity of these services. And we will work with the district teams to continuously look at the data. What is it telling us in terms of the outpatient numbers? Have these reduced in areas that are at high risk of Ebola? Have people shunned facilities? How can we optimize provision of these community of these patients, maybe through the community structure? So these objectives really look at aspects of ensuring that we can continue provision of services within this. And these essential services really are a wide range of these, coming all the way from health promotion, environmental health, prevention and management of communicable, non-communicable diseases, reproductive, maternal, newborn, and child health. And these guidelines will be shared with us here, just so that we're able to understand what happens in which different aspects. So the coordination structure runs all the way from the national, and currently it's chaired by Commissioner Communicable and Non-Communicable Prevention and Control. We have the regional structure as well as the district structure up to the village level. And this is just, as we look at strengthening these aspects, we look at what roles can we play, how do we establish triggers and thresholds so that we are keeping an eye as well on that reallocation of these routine services. How do we ensure that we have identified gaps and the need to remap any referral pathways? This is very critical. And then the relevant essential services, are these being provided at these facilities in this high-risk district, as Dr. Sandy mentioned, but also guide the optimization. Which other platforms can we utilize to ensure that we reach these patients? And the next slide really looks at what are those key immediate actions that we can utilize to reorganize and maintain access to these essential services. And one, like Dr. Elizabeth has mentioned, it's orienting the healthcare personnel to disseminate that information on the critical services, but also ensuring continuity as we pull out a number of health workers that are being contact or are in quarantine, how do we make sure that there is triage still happening? How do we make sure that there is still screening of these patients on arrival to really facilitate that early recognition? You will notice that certain areas may remain blank because of a number of people that are not available, but it's important we ensure that we can move the staff around. So it's important for us to do some health workforce planning, identifying those mechanisms where we can have additional staff, reassign certain staff who are in areas in that facility that are not crowded to maybe come in and support areas that have been left as gaps. So this really looks at how best do we reassign and redistribute the health workers, establish mechanisms of isolation, repurpose some of the rooms that we have within the facility. If we don't have isolation space, but how do we repurpose some of these rooms? And this guidance is within the different aspects on how best we need to move forward to ensure that patients that have been suspected are held in a certain area, but also the referral of these cases. Dr. Elizabeth has really talked about the IPC, and I would not want to go further into this, but this is just to let us know that we need to really apply these precautions to ensure that we can safely administer care to patients that continuously come into our facilities, but also protect the health workers. It's important that we protect the health workers so that they're able to care for our patients. We utilize different aspects, the hybrid, both virtual and in person, to support the health workers, but also deploy additional staff. So usually over the past, what we have always done is utilize find the number of health workers that have been put in quarantine and be able to at least substantially support and deploy a certain percentage of these health workers to ensure that there is continuity of care within the facilities where the index cases have been picked. So it's important that we're able to identify, do that bit of facility readiness and be able to support this. If we have been able to reassign, where we still have gaps so that we're able to deploy some locum staff for a short period of time based on the support required. And this is all done to ensure that we continuously provide the services, but also establish mechanisms to maintain the availability of essential medicines, equipments, and supplies. Like we mentioned, there are a number of patients that are in chronic care that require medicines. So we identify different mechanisms to provide these to the patients, but also monitor the stocks and identify that the stocks for other commodities are still available. Those that have run low are able to be supported to have these supplies beyond that come into the facility. I've already talked about rapidly redistributing the health workforce capacity, where we do task shifting, reassignment, but support the different facilities as well with additional staff. Keeping in mind that it's important to protect the mental health of the health workforce while we respond to these public health emergencies. And then optimizing the community health platforms, utilizing the outreaches, but also community-based programs. But these done in line while keeping note of the infection prevention control measures, so that we're able to reach out to some of these patients that shun facilities or fear to facilities if a case has been identified or located in a certain area. We also review and reinforce the referral system for essential health services at the community as well as the facility level. We also adjust hospital admissions and discharge protocols. How do we ensure that patients that have come in and are now well are able to move as fast as quickly out of the facility so that we don't have reinfections coming through because of long inpatient stays. So some of these are also aspects that we look at to ensure that this is done. And we have these different guidance based on what we need to do, as mentioned in detail. If a mother is breastfeeding and she's positive for Ebola, the baby is positive for Ebola, what would we do for this particular patient? But then if the mother is negative, and if the mother is positive and the baby is negative, what would we do? And the nutritional aspect, as well as the mental and management of these communicable diseases, is all out, spelled out, and the guidance provided within these guidelines. I will not move into this because this has been really worked and supported by the IPC team, and the importance of communication. But lastly, I think I want to speak to the monitoring and evaluation so that we're able to utilize. We found challenges when we have response to the public health emergencies. We have routine data stored in certain areas, and that affects what the need to respond to challenges if we note any. Especially, we have the indicators that we look at, the weekly indicators, but also the 20 key indicators that give us a proxy of what is happening in these different facilities. And therefore, when we have challenges of data not coming through, it affects how we are able to support these particular facilities, but also to note if we are having challenges as to the other routine care services. So it's very important that we're able to look at these aspects, and we will have, I believe, more webinars where we'll be able to expound on what we do for maternal child health, on what we do in nutrition, how do we feed these people that have been affected with EVD, but also the normal scenarios. How do we manage patient that has a comorbidity of both malaria and Ebola per se, because many of these have similarities, and yes, similarities, and we note that most of these patients, and over time we've realized about 50% of the patients that we had within our quarantine or different centers have malaria as well as a comorbidity. So it's important that we're able to manage both the malaria but also the Ebola in this particular cases. So it's important that and then a chronic care patient, a patient that is been having taking drugs for other conditions like HIV, like TB. We've seen mortalities increase there for those that have comorbidities with the Ebola. So it's important that we're able to have that multidisciplinary team, but also know how best we interact with such patients to be able to continuously provide care for both. So this is lastly really the readiness assessment that looks at that particular facility, if the staff that are available, and we are having challenges, and this informs key take home is it's important. The key take home is important for us to note that we need to increase our index of suspicion, but also to note that we need to continuously provide these other essential services while we respond to Ebola, because we've had more mortalities come out of these other routine conditions if we do not take keen interest. Thank you very much, and over to you, Chair.
Thank you so very much, Dr. Maureen. I'm to hear. Colleagues, we are coming to the end of the presentations, and we will provide an opportunity to all of us to be able to weigh in on the presentations that have been delivered unto us today. We came from surveillance that gave us a picture of what we are seeing in the country right now, from the time when we had the first case confirmed, and then the second case, and what the different risks that have been since established in the country. We went to what exactly happens when a case is confirmed, and how that case is managed, or how the patients are managed and how they are cared for, and what we as healthcare providers must know when it comes to care for patients confirmed positive for Ebola, depending on their severity of disease, and what happens to the suspects as well. From that, we went deeper into how we should protect ourselves as healthcare providers with infection prevention and control, what our responsibilities are as healthcare providers at the front line, who are caring for patients day in, day out as our daily business, patients will present with any forms of signs and symptoms, how shall we be able to screen them out to establish what the risks are and ensure that for those that are positive for or that meet the case definition for a suspect are isolated at the screening point and prevented from mixing with the rest and therefore breaking the chain of transmission. And for those that are good, then they are allowed to proceed. As healthcare providers, what is our role at that level in ensuring that we are able to ensure the de-escalation of this outbreak? And from that, we have realized that as we respond to the outbreak, essential healthcare service delivery is a must continue. And therefore, it's incumbent upon us as healthcare providers to ensure that as we are responding, we do not compromise on the other healthcare services that we are expected of in the hospital space and at community level, because then if we do, we will have mortalities coming in from these other conditions other than the Ebola that we're worried about. And therefore, it's important that we preserve them as well. So it's at this point in time that we will dive into the questions and answer. There are a few questions that were asked on the platform, and I believe the presenters have been able to pick those questions, but we will also allow a set of 15 questions. Be straight to your with your question, straight to the point. Do not explain so much. Just go straight to the question that you want and direct it to the different presenters so that we can be able to redeem time. And in that regard, we'll be able to have each one of us get an opportunity. We are providing for 15 questions and we'll take them in a set of 5. And after 5, we'll be hearing again from the presenters so that we can have a clarity of flow of this webinar. So we will, at this point in time, open the microphones and so you will raise your hand and we will select you so that you can be able to speak to the meeting. For the rest of us who are not speaking, we kind of request that you keep your microphones closed so that we do not disrupt the meeting. We'll start with Alex Opio.
Yeah, man.
Do not go into introducing yourself.
Yes, we continue to thank you for being part of this great session. We believe you've learned something from this session. So this session was basically to tell us about Ebola outbreak. As you all know, there has been an outbreak of Ebola in the eastern part of the Democratic Republic of Congo. And Congo being Uganda's neighbor, we've definitely have to take some precautions to ensure that we don't get affected so much by Ebola. Speaking right to you right now is Dr. Sechanzi Henry, and I just want to summarize the few things that have been covered in this webinar. As you all know, that there was an outbreak of Ebola in the eastern part of the Democratic Republic of Congo, and as you all heard, there was a case that came to Chibuli Hospital. Chibuli Hospital is right here in the center of Kampala, there was a case that was managed. At the time of the management, the people who managed didn't know that actually they were having Ebola with them, but it turned out that actually the case turned out to be an Ebola case. It's quite unfortunate that the patient passed on. May his soul rest in peace. But all this was done after he had passed on. So after he had passed on, the AVRI and the Ministry of Health picked interest in his condition. They went ahead and did the analysis, they did the PCRs, and they found that this person had Ebola, which caused his death. So we have an outbreak, and according to the current reports, there has been a confirmation that actually Ebola is right now in Uganda. A few days ago, we didn't know that actually had Ebola around with us, but for now it has been confirmed that actually we have Ebola, and it's because of that reason that the celebrations for the Uganda Matters Day have been postponed. We all know that every 3rd of June, Uganda celebrates the Matters Day, events that happen around Namugongo, and we were expecting so many visitors from all over the world to come and be part of this great event, but because of the Ebola outbreak, this has been postponed to a further date. So it's quite unfortunate we will not have the celebrations for the Uganda Matters Day. It's simply because of Ebola. And now, as you all know, that with this current outbreak that started in the Democratic Republic of Congo, Uganda would definitely be one of the possible places that Ebola can spread to, as Uganda and Congo are deeply connected because we share the same border. There's so much trade that happens between Uganda and Congo. Traders always move from Congo, come to Uganda, buy goods, they go back to Congo and all that. So because of this, so many cross-border exchanges, it's very possible to have these Ebola cases shipped into one country to another. And there are quite a number of refugees. We've all heard about the M23 who are in Congo, and they're fighting every day, and we've had cases of people being killed. So probably some people could run away from Congo, come to Uganda simply because of the war, and they could ship in these Ebola cases to Uganda. As of today, you understand that Uganda has confirmed a case of Ebola, which is quite unfortunate. And like I said earlier on, some of these cases could be shipped into Uganda through some of the migrations that happen, people moving from Congo to Uganda, people from Uganda to Congo for businesses. We have quite a number of refugee flows, the number of mining routes. You all know that Congo has a lot of minerals, and some Ugandans tend to cross the borders to go and acquire some of these minerals. So some of these could ship in cases of Ebola. There are many family ties. There are people who you can find a Ugandan who married to a Congolese, you know, and as maybe their wife or their husband comes to meet them, they bring in Ebola cases. So there are really many ways in which this virus can be transmitted. And as we've heard from most of the experts that have been on this call, this case is very contagious, that if somebody has it, they can easily pass it on to another person. So Uganda for now has already confirmed an imported Ebola case that has been linked to the outbreak that is happening in Congo. So this is not really a Congo's problem, no. In my culture, Buganda here, we have a saying that if your neighbor's hut catches fire, definitely you cannot be there and jubilate because your neighbor's hut has caught fire. Probably you have to be out there and you have to go and help your neighbor put down the fire. So if our neighbor Congo has had some cases of Ebola, why don't we come and be part of the process of helping them handle this Ebola outbreak? You understand that Uganda for the recent past has been very pivotal in handling Ebola cases, in handling outbreaks. Uganda almost won an award for the COVID-19 pandemic. Okay, so with this new case of Ebola, definitely Uganda has to come in handy and support with the process of overcoming Ebola. I hope you understand that Ebola is a viral hemorrhagic fever, and by viral hemorrhagic fever I mean that it's one caused by a virus, the Ebola virus. It's hemorrhagic in that this disease can make somebody bleed. Okay, somebody could bleed out. Okay, in the mechanism or the pathophysiology by which this Ebola virus causes disease, it can actually make somebody bleed out, and there are quite a number of mechanisms which I think if you have some time I'm going to explain to you. Okay, but basically this disease can make somebody bleed out, and because of this somebody could become anemic, and they could easily die. So this is a viral hemorrhagic disease, and it's caused by viruses which belong to a genus called the Ebola viruses. This disease can spread very rapidly because the way it happens is that the virus can attack the immune cells, it can damage the blood vessels, it can disrupt the normal coagulation processes. You understand that our bodies are designed in a way that should there be a challenge with maybe the blood vessels, the body is well built to handle or correct its problems. So there could always be a disruption in the coagulation processes, and this can result into widespread inflammation as well as causing organ failure. So because of this organ failure, somebody could actually easily die because of this Ebola virus. Now, how does this virus enter our bodies? Now, like you've had our experts explain to us how this whole process happens, is that this virus enters through a broken skin. Okay, you could have maybe a wound or a broken skin, you got bruised, you have an accident. That can actually be an entry point for Ebola into your body. It can also happen through some of the mucous membranes, and by mucous membranes here, experts are trying to talk about things like the eyes, the nose, the mouth. Okay, so Ebola can actually gain its entry into your body through any of these body parts. Also, those individuals who have been affected by this disease, they can easily spread it to others through blood or body fluids. You understand that there are quite a number of body fluids. This includes blood, tears, saliva, and sexual fluids. Okay, so you could have your partner out there and they have had Ebola and they come to you this evening and you have an intimate activity with them and you end up getting Ebola. So Ebola can actually be spread through a number of ways, including some of these. That aside, the moment Ebola enters your body, it has some target cells that's going to affect. You know, our bodies has some defenses. So these defenses are what maybe I would call our soldiers that are supposed to be there and protect us against diseases. So we have quite a number of cells that are meant to be there to protect us from getting diseases. This includes things like monocytes, macrophages, and dendritic cells. So these cells are like our body defenses. Should any disease come to attack us, some of these are there to protect us and ensure that the disease doesn't have a lot of impact on our bodies. So Ebola could actually affect all these, and in a way it affects us. Now, these cells, the moment, for instance, Ebola has affected your cells, these cells are going to be transported to various body parts. Some of these include the bloodstream. Of course, you all know that blood moves all over the body at any time. This blood is going to move to any part of the body. For instance, blood can actually pick up this virus from wherever it is, assuming you've had it enter your body. So this virus can actually spread from one part to another through the bloodstream. But apart from the bloodstream, we also have other mechanisms by which this virus can be transmitted. For instance, you have what you call the lymphatic system. Now, this lymphatic system, I understand that many of the people on the call may not be very familiar with what a lymphatic system does, but basically it's one of the systems in our bodies that is responsible for ensuring that our bodies are safe. Okay, it filters, removes any toxic materials that could be there in the blood and ensure that we are safe all the time. So in the way Ebola functions is that it could actually be spread through this lymphatic system and the bloodstream and can enter any part of the body. Now, the moment this Ebola virus enters your body, it's going to attach, okay, to your body cells, and with that it will replicate. By replicate, I mean it's going to multiply many more times. So this Ebola can bind to the host cells, which are your cells, and then it enters into these cells by a process called endocytosis. Now, endocytosis, much as it might be a very difficult word for you to understand, but it means that these cells are going to take up this virus, okay? And then this virus is going to enter into your body, and the moment it's inside your cells, there's so many things that could happen. We could have this viral RNA, the genetic material of the virus, passed on to your cells. Okay, so your cells are going to take up this RNA of the viruses, and then its RNA is going to direct your cell to synthesize or to make proteins for this virus, and that's how this virus takes advantage of us. So it's very opportunistic in that it's going to use it's going to use the cell machinery. It's going to use your cells to make whatever it wants. That's the tricky thing about this virus. Okay, it's very tiny virus, but the moment it enters your body, it's going to use your machinery, your cells, to produce and cause more havoc onto your body cells. So the moment this virus enters your cells and it causes your cells to change the way they function, is going to result into so many viral proteins synthesized. By this I mean the cells are going to, this virus is going to make your cells produce proteins that the virus needs. It's going to make your body produce proteins that your cells are going to need to cause more havoc onto the body cells. And from this, we're going to have very many new viral particles assembled, and at the end of the day, we are going to have virions, we call them virions, those small viral particles produced, and they're going to go and cause much more havoc onto the body cells. So there's rapid viral replication as well as a wide dissemination. Definitely from this, we're going to have so many virus particles formed that are going to move to the different parts of the body and they cause havoc. Now, these viruses are going to cause what you call immune system dysregulation. Okay, so one of the major features of Ebola and in its pathophysiology is that it causes uncontrolled immune response. Okay, in other words, the body is going to be overwhelmed in its response towards the Ebola, and by that, the body is affected in so many ways. You could have what you call a cytokine storm. I hope you've heard all about the cytokine storm. So basically, the cytokine storm, you're going to have some sort of an exaggerated response towards these so many virus particles, and by that, you would have so much tissue injury going on. So the infected macrophages are going to release a lot of cytokines. We call these cytokines, and some of the most implicated cytokines include the tumor necrosis factor alpha, the interleukin-1, interleukin-6, as well as interferons. Now, all these cytokines are going to make the body get overstimulated, and by this, they're going to be much more damage. So some of these cytokines that have been released are going to result into fever. Okay, so these patients are going to present to us with fever when their body temperatures are high. We all know that normal body temperature is around 35.5 around 37.5. So you're going to have patients coming in with temperatures more than 37.5 simply because they're having too much of these cytokines that have been released in the body of humans. You could have capillary leakage. How does capillary leakage happen? Now, capillary leakage is going to happen because these viruses are going to affect our endothelium. By endothelium, I mean that inner lining in the blood vessels. Okay, so because the viruses are going to cause some endothelial damage, there's going to be damage to the endothelial lining, and that will result into extravasation. Some of the body fluids inside these blood vessels is going to extravasate, and as it extravasates, it's going to cause most of the fluids that are intracellular to go into the extracellular space, and that's what you call the capillary leakage. Definitely from this, we are likely to get hypotension because as we are losing intravascular volume, okay, we can get into hypotension simply because of the capillary leak that's happening because of the endothelial damage. And we all know the consequences of hypotension. That hypotension can always get us into shock. Now, there's also going to be a suppression in the adaptive immunity, okay? So the virus is going to impair the dendritic cells, and that's going to affect the proper activation of some of the lymphocytes. We all know that our bodies have what you call B lymphocytes and T lymphocytes. These are some of the cells that are there to protect your body and prevent you from getting any significant diseases. For instance, T lymphocytes are helpful in fighting so many viral infections. Same applies to B lymphocytes, and we all know that our B lymphocytes, together with the B cells, are responsible for the formation of the antibodies that protect us against so many diseases. So, with this virus affecting our adaptive immunity, it's going to impair dendritic cells, it's going to impair the proper activation of the T lymphocytes and the B lymphocytes, and with this there's going to be immune dysregulation, which will result into a lot of catastrophe. So as a result, the body will really struggle, like a real struggle, to mount an effective immune response to fight against diseases. And this is one of the things that have been implicated in the way this Ebola causes disease to us. Now, because of the so much endothelial damage and the vascular leak that happens after you've had this Ebola, there's going to be some inflammatory response. Okay, there's going to be an inflammatory response, and this inflammatory response is going to damage the endothelial cells that are damaging the blood vessels. As a result, there's going to be an increased vascular permeability. Some of these contents that are inside the blood vessels are going to extravasate out, and they move into the extracellular spaces. There will also be plasma leakage into the tissues, and this could explain why the edema happens, as well as a reduced blood volume, as most of these contents inside the blood vessels extravasate out. So definitely the blood volume will have to reduce. All these events are going to result into hypotension, the blood pressure is going to drop, there will be multiple organ failure and hypoperfusion, and all of these will result into shock. Apart from those events that result into shock and reduced function of organs as well as multiple organ failure, we could have what we call coagulation abnormalities. Okay, the body's ability to form a clot, to dissolve a clot, there's going to be a disarrangement in this process. So Ebola triggers what we call disseminated intravascular coagulation, also called DIC. I imagine the doctors on this call have at least heard about DIC. So basically DIC is disseminated intravascular coagulation. And what does that mean? So by DIC basically, we're trying to mean that the body is going to reach a phase whereby there's so much coagulation, okay? And with this coagulation, you're going to use all the platelets in the body, we're going to use all the clotting factors in the body, and because of this, there can be a very, very serious catastrophe in the body. How does this happen? Now, tissue factor releases and activates the coagulation pathways. You've all seen that with this Ebola virus, there's going to be activation of so many cytokines, tissue factors, that in end activate the coagulation pathway, the pathway that's supposed to ensure that we don't coagulate inside our bodies, we don't bleed excessively. So, because of this too much coagulation that is happening, the clotting factors are going to be used up, okay? Your clotting factors are going to be taken up during this process. I hope you're listening and you're continuing to enjoy this program. My name is Dr. Sechanzi Henry, and I'm here to give you the latest about Ebola. We have just had a session from the ministry officials telling us about Ebola, and this is happening to us because, yes, there have been some cases of Ebola. We all heard how Congo had some cases, and because of this Ebola that you've had the postponement of the Matters Day celebration. And right now we're talking about the coagulation abnormalities that could happen, and we're talking about how Ebola could result into DIC, or disseminated intravascular coagulation, and we've discussed how most of the tissue factors are going to release or activate the coagulation pathways, and with these we're going to have the clotting factors becoming depleted, and because of this we shall have clotting and bleeding occurring. So some of the manifestations for this include peteche. Peteche means bleeding under the skin. The patient is going to come to you as a doctor, and they're going to be having peteche. Okay, they could be having enchymosis. By this we mean they're bleeding under the skin. They're having these small or large bleeds, and all this should show you that there's a problem with the bleeding process. Probably the platelets or the coagulation factors are having an issue. Sometimes patients could actually come in with internal bleeding. You must have heard about strokes. You must have heard about upper GI bleeding. So if a patient comes to you right now and you know they're having futures of bleeding, don't just treat it lightly. It could be an Ebola case, okay? And you're the person at the front line to address this. So patients could actually come in with internal bleeding. It shouldn't surprise you that a patient can come to you when they're having a stroke, simply because they bled in the brain, and it's happening because of Ebola. So this Ebola can make people bleed from anywhere. It could be upper GI bleeding, it could be Bring you the latest about Ebola. About Ebola, and right now we are talking about the different organs that could be affected simply Are you there? Can you hear us? We just need to get some confirmation that you can hear us. So, can you hear us? Okay. Awesome. I will continue to thank you for being a great audience, for listening up to this moment. At this point, I want to talk about how Ebola can result into shock and death. As you heard from our experts earlier on in this conversation, Ebola could result into a very severe disease and consequently death simply because of the massive fluid loss. Okay, what do you mean by this? We've seen how Ebola can result into extravasation, that is fluid leakage from the intravascular compartment to the extravascular compartment. So this massive fluid leak could actually get us into Ebola. That aside, we've talked about the vascular leakage. These endothelium are going to become more permeable to the fluids, and all these fluids could extravasate and result into more fluid extravasating from the extravascular space that can result into shock. That said, we could have myocardial depression. We all know that myocardium is actually the heart muscle. Heart muscle, to function well, it relies on electrolytes, including sodium, potassium, calcium. So if there's a derangement, in the way these electrolytes are functioning, it could actually get us into myocardial depression, and this could result into damage. We have already talked about DIC, which is disseminated intravascular coagulation, that can actually happen because of Ebola, and because of all these things, we could end up having multiple organ failure. So all these processes could result into hypovolemic shock, septic-like shock, as well as death. As you all know, Ebola is a very, very fatal disease. In summary, I want us to know that Ebola can enter our bodies through broken surfaces, through mucous membranes, and by mucous membranes we meaning the mouth, the nose, the eyes. Okay, and the moment Ebola enters our bodies, it can affect us. It can affect our immune cells, the cells that are supposed to be there to defend us. This includes the macrophages, the dendritic cells, and other cells that are supposed to be part of our innate immune system. These viruses tend to reproduce very, very fast. They multiply, reproduce, and with this, they can cause a cytokine storm. We've seen that this virus can result into a rapid production of cytokines, the interleukins, the tumor necrosis factors, which in end cause massive damage to the body. Some of the damage happens because of the endothelial injury, as well as the vascular leakage, which results into a reduction in the intravascular volume, and our patients could get into shock. That said, we've seen that Ebola could affect our coagulation abilities. Okay, so this Ebola, because it's going to result into DIC, that is disseminated intravascular coagulation, it's likely to result into consumption of all the clotting factors in the body, and because of this taking up of all the coagulation factors in the body and the platelets, we can end up with coagulation disorders, and the patient could bleed out. Okay, and that's what makes it a very, very difficult disease, in that it can make somebody bleed from any point of the body, including the brain, including the gastrointestinal system, including the skin. Okay, so all this further causes much more damage. That said, I want us to all know that the patients could actually get into what you call hypotension, and by hypotension we meaning a low blood pressure. How does a low blood pressure happens? The low blood pressure is going to happen simply because your body is having most of these fluids leaking out of the intravascular volume. You're having a vascular leak, so you end up having hypotension, and this hypotension could get us into shock. Okay, patient is going to have cold extremities. Okay, low pressure, low BPs. The pulse might be high as a response because of the sympathetic activity, and all this is going to further cause much more damage. Confusion and coma, simply because there's poor cerebral perfusion as well as the metabolic disturbances. So the most important complications that could happen because of Ebola include the following. One, patients could become dehydrated. Why are they getting dehydrated? They're getting dehydrated because they're losing fluid. Okay, we've seen the mechanism by which most of these fluids are going to extravasate and move outside of the intravascular compartment to the extravascular compartment. So we could get severe dehydration, which is quite unfortunate. And because of this dehydration, the patient could actually get into shock. That said, a patient can actually get electrolyte imbalances. Okay, these electrolytes are being consumed, others are being lost, others are vomiting and diarrhea, and all this can cause much more damage. We could get acute kidney injury, most especially prerenal AKI. How does prerenal AKI happen? So prerenal AKI is going to happen because you're having reduced intravascular volume. The blood flow to the kidneys has reduced. The renal perfusion pressure has reduced. And when the renal perfusion pressure has reduced, less blood is going to the kidneys, they're filtering less, they're having reduced oxygen supply. We could end up having a prerenal AKI. We could have acute liver failure. You've seen the mechanism by which the acute kidney failure happens. We can get DIC, that's disseminated intravascular coagulation, which is going to take up most of the coagulation factors in the body. And because of this, coagulation factors are going to be taken up, pressure are going to be taken up, and this is going to cause further damage. That said, we could have secondary infections. There are many opportunistic infections that can take advantage of the fact that the body immune system is now weak. Okay, and some of these infections could come into handy. Things like bacterial infections. Okay, as you can see in that slide that you're casting onto the screen, some of the objectives for the guidelines during these public health emergencies. So basically, we want to strengthen governance, okay, and coordination mechanisms for essential health services to ensure continuity of healthcare delivery at national and subnational levels. So we need all the healthcare facilities, both in capital cities or centers, as well as outside countries, to be able to coordinate these mechanisms and ensure that our population remains safe. We want to provide guidance, okay, on the set targets and immediate actions to organize and maintain the access to essential health services and reduce unnecessary deaths, as well as we need to continue to monitor the continuity of health services and provide support to sustain quality services. So with this outbreak, we still want healthcare to be accessed by the general public. We still want all our people to be able to access care whenever they need it. And at the end of that day, we want all our populations to be well. Okay, so that said, I want to highlight one thing. Ebola is not a new thing. It has been available for some time. And if you think Ebola is happening to us for the first time, you're really, really mistaken. So I want to take us through the history of Ebola in Africa, Uganda, and the entire world at large. So this Ebola virus was first identified in 1976 during the two simultaneous outbreaks that happened in Sudan and the Democratic Republic of Congo. I remember in around 1976, the president of Uganda at the time was His Excellency Idi Amin Dada. I think that's a year. I think did he come in 1972? You could remind me, but I think at this time he was the president. So this virus was named after Ebola River in northern Congo near the outbreak areas. This was the first recorded outbreak, like we said, it was 1976, and this happened around Nzara, Sudan. Okay, Sudan is Uganda's neighbor, and at the time, the virus species that was named is called Ebola virus, Sudan. So it was called the Sudan Ebola virus, and it's estimated that at that time there were around 284 cases that were confirmed at the time the Nzara, the Sudan Ebola virus was detected. Okay, then that same year we had another outbreak in Zaire at a place called Yambuku in Zaire, and this one had more cases than the Nzara Sudan Ebola virus. For this one had 318 cases. As of now, scientists have confirmed that actually Ebola is transmitted through the reuse of contaminated needles. Okay, reuse of contaminated needles. We all know that Ebola is a hematological disease that can be spread from one person who is infected to another through some of these contaminated needles, okay, or some of any other contaminated stuff. That's why in hospitals, efforts are made to ensure that patients have sterile equipment. We no longer use the needles. Remember back in the days when I was young, our parents could use needles. Okay, they would go use the same needle on 2-3 different people, and all they could do was to boil the needle and use it on another person. Times have changed. Okay, it's no longer allowed to reuse the needles. At the time, it was also confirmed that Ebola could actually be transmitted through poor infection control. Okay, if you don't practice proper infection control, you could actually spread Ebola from one person to another. And that's why we encourage doctors to always observe IPC. By IPC, we mean infection prevention and control. Okay, before every patient, you need to wash your hands. After every patient, you need to wash your hands. Before touching a patient's body fluids, you need to wash your hands. After handling any patient, you need to wash your hands. And with that, we can strongly control the spread of Ebola virus. Okay, so with this, we encourage our healthcare workers to ensure that they observe the the infection prevention and control measures. And with this, we can get onto the foot of Ebola. We can control the Ebola if we observe proper hand hygiene. Things like hand washing, using alcohol-based sanitizers, using protective equipment. All these are very, very important when it comes to controlling Ebola. Less of that, we're all victims. Even you, doctor, attending to a patient with Ebola, if you do not practice proper hand hygiene, you can actually cause the disease to spread further. So infection prevention and control goes beyond just hand hygiene. There are quite a number of other things, including isolation. Okay, with this Ebola, realize that if a patient has Ebola and they are being confirmed to have Ebola, or they are being suspected, it would really be important to isolate them. Let's put them in a safe place where they are not going to spread the disease to others. By this, if maybe they are still suspected, we can observe them as they are in their safe spaces. They cannot spread the disease. And as you're observing them, you're ensuring that they're not passing the virus onto other people. So, things like isolation, they're all part of the infection prevention and control. If your doctor is going to attend to Ebola patient, do you know how you should dress? They have guidelines on how you should drone. Okay? You're expected to be in full protective equipment, full protective gear to ensure that the virus is not spread from one person to another. If we all practice these safe processes of ensuring that Ebola is not spread from one person to another, we can actually prevent the spread of the virus from one person to another. Okay. I've also mentioned about ensuring that we do close family caregiving. If somebody has Ebola and is confirmed, there's no need why this person should be close to their family members. That's why it's important to isolate them, because if you don't isolate them, they're going to spread the disease to their family members. If someone is a teacher, for instance, and they're having Ebola and they're not isolated from their family, they could go on and spread the virus to their families. Their family members could spread the virus to other community members. The children could spread the virus to other people in the community. At the end of the day, we might end up having the whole community getting Ebola. So we need to do proper care to our family members. Sometimes in other unfortunate events, we could lose beloved ones to Ebola. And should you lose a beloved one to Ebola, should you really bury them by yourself? The answer is no. There are well-established guidelines on how Ebola patients should be buried. You don't have to bury them yourself. Okay? Back in the days when we had some of these cases, the government could bring in people that are trained to handle these Ebola cases. They would come and bury for us. Okay? Definitely the same precautions have to be applied. Even this time round, you don't have to bury your loved ones when they have died of Ebola, because each time you spend this money, you're increasing the risk of getting the virus by yourselves. And this brings me to the point of traditional burial practices. Some of these are ready to be foregone, especially if somebody has died of a disease that is likely to be Ebola. There are quite a number of other outbreaks that have happened in Uganda and Africa at large. And there is an outbreak that happened around Central Africa. Okay, there have been quite a number of outbreaks that have happened in Central Africa from the years of 1976 up to 2012. And these have been quite a number of them. Some of these outbreaks have happened in countries like the Democratic Republic of Congo. Others have happened in the Republic of Congo. I imagine for now, you understand that the DRC and Congo are different countries. It's not the same country. So we've had some outbreaks happen in the Republic of Congo, as well as some that have happened in the Democratic Republic of Congo. But that aside, other outbreaks have happened in Gabon as well as Uganda. And all these outbreaks were usually localized in rural forest regions, and they are linked to contacts with infected life. Okay, so most of the outbreaks that have happened in the recent past have a bit of bearing to the wildlife. chimpanzees, monkeys, to mention but a few. There are so many wildlife organisms that could carry Ebola, even if maybe Ebola doesn't cause direct damage to them, but for them they can live with it. So most of the outbreaks have actually been traced, and it has been discovered that there has always been a bearing to some of these wildlife organisms. Okay, and then of course, much as most of these transmissions have happened because an organism has, maybe a chimpanzee or a monkey has passed on the organism from itself to a human. There's also been quite a number of human to human transmissions that have happened. So because of this, we encourage our people to be very careful, especially if they're going to visit the wildlife. You don't have to come so close to some of these organisms. You don't have to come so close to the chimpanzees, especially those that show some signs. There have been also a number of West African pandemics that have happened. I can tell you that from 2014 up to 2016, quite a number of pandemics have happened even in West Africa, and these became some of the largest Ebola outbreaks in history. Okay, I can tell you that there are quite a number of countries that have had outbreaks of Ebola. Some of these countries could include Guinea, okay, Guinea, Liberia, Sierra Leone, okay. Some of these countries have actually had outbreaks. Quite unfortunate, okay. And overall, these outbreaks have resulted into so many people dying, okay. For instance, it's estimated that close to 28,000 cases have happened, and of these there have been more than 11,000 deaths. That's slightly less than a half of the 28. Okay, so these deaths have happened simply because of Ebola virus. Quite unfortunate, and all these should show us that there's so much that you have to do to ensure that we control these Ebola outbreaks and chase them out of our settings. That said, I want to talk a little bit about the historical significance of this Ebola. Now, the first urban Ebola pandemic happened, like we've said, and if it happens today, okay, if you have a major urban Ebola epidemic, it could spread very easily to other countries. We all know that as of today, this world is a global village. If somebody has Ebola, they could easily pass it on to their neighbor. The neighbor could be moving to another place the next 2 days. They're going to go and spread the virus. If this pandemic or the outbreak happens in Uganda, this epidemic can actually be transmitted from Uganda to any other country in no minute. Okay? So, the world these days is a global village, and we need to be very, very cautious of our movements, of our behavior, and should we have any suspicions of Ebola, we have to take extra precaution. Now, there have been global public health concerns happening because of Ebola. Because if somebody has Ebola, for instance, in the Democratic Republic of Congo, and they have to travel to the United States of America tomorrow, they could actually reach USA when they are symptomatic, and in that way, they could take this virus to USA. We've had many tourists move from different countries, come to some of these African countries for tourism. And if, by any chance, one of them has Ebola, or they're going to pick up Ebola, definitely affects economic activity. So, that's why this Ebola has to be looked out with a very, very keen eye. Some of these epidemics could cause public health concern, and on the positive side, they have led to an accelerated vaccine research. So, international organizations, including the WHO, the medicines, apart from WHO, there are many organizations that are working towards ensuring that we get vaccines for Ebola. These are doing everything possible to ensure that we get vaccines. And recently, we've heard that some countries have actually develop some vaccines. We heard recently that Rwanda had started putting out some of the vaccines for Ebola. So there's some light at the end of the tunnel in terms of vaccines that could help control Ebola. Democratic Republic of Congo has also had some outbreaks, especially during 2018 to 2020, especially the eastern part of the country. And some of these outbreaks are complicated by the fact that there is armed conflicts. Okay, there's so many conflicts going on in the eastern part of Congo, and some of these contribute to the escalation of these pandemics, as well as there's so much community mistrust. That Uganda has happened. But that aside, even in 2007, there happened to be another big outbreak in Uganda. This one was in Bundibujo district, and this was named Bundibujo Ebola virus. And with this, there was a discovery of a new species. And I think that was the first time Bundibujo Ebola virus was mentioned. 2011 here, recently, Luwelo. Okay, Luwelo had an outbreak of Ebola virus. And this time round, the subtype was Sudani Ebola virus. It was quite a small outbreak, but just 1 year later, Chibale came. Okay, Chibale had Ebola. Again, it was the Sudan Ebola virus. And with this, there are quite a number of districts that were affected, especially Chibale and the nearby districts. Same year, Luwelo did not survive. Luwelo was a victim. There was a Sudan Ebola virus, and this was a separate outbreak. 2019, Kasese got affected. You all know that Kasese is quite close to Congo, and it's argued that some of these cases were imported from DRC into Uganda. So it's assumed that it was because of these border transmissions that this virus came into Uganda, and definitely the people in Kasese, we all know that Kasese is quite a mountainous area. 2022-2023, Mubende and Central Region did not survive Ebola. Sudan Ebola virus again was there, and this was a large recent outbreak. I'll just talk a little bit about some of these outbreaks that I've highlighted about, and we see what basically their impacts were and how much they affected our populations. The 2000s to 2001, that's the bull outbreak. It cannot go without mention. So basically, the 2000 to 2001 bull outbreak, this was the most severe Ebola outbreak. This was bad. Okay, this Ebola was gumite, if I'm to use the current language that many Ugandans use currently, because it came with all the might, with all the energy, and it affected a very big number of people. It's assumed to be one of the biggest that have happened in Uganda's history. It affected quite a number of areas, including the following. Gulu was affected. Mbarala was affected. Masindi was affected, and its impact was huge, as more than 400 cases. Can you imagine? 400 cases were involved, and then there were over 200 deaths. This happened in 2000, 2001. Those of you on this call, I don't know where you were at the time. For me, I think I was in primary school. You can as well tell us where you were at the time. Okay? But this was a very, very serious issue at the time. Okay, that aside, there's some important historical facts about this Ebola virus. What are these? This Ebola virus strengthened Uganda's disease surveillance systems. So this was like a trigger to Uganda to strengthen the surveillance systems. That aside, this Ebola improved Uganda's infection prevention practices. So there was so much that was learned, and it all impacted on the practice. Okay, so basically this outbreak that happened in Masindi, Gulu and Imbarala greatly affected so many lives. Like I told you, there are more than 400 cases of Ebola that happened, and of these, there are 200 deaths. Imagine 200 people dying simply because of Ebola virus. Very, very big number. That aside, there are some historical effects that this virus caused, including the fact that it strengthened Uganda's health system surveillance. So Uganda was a little bit more awake. Our leaders got to know that, hey, at any time, we could get affected by this problem called Ebola, and for that reason, we need to strengthen our surveillance systems. Okay? So our system was strengthened, and there was an improvement in the infection prevention practices, and somehow that has helped in the control of so many viruses. Because with that outbreak, there's so many lessons that we are learned. Okay? And these lessons have, in a way, impacted so much on what we do currently, and that even if any outbreak happens right now, there is always so much that we've learned from the past that we can use and avoid this virus causing a very, very huge rampage onto our communities. And then, of course, with this new with this virus that happened in this year of 2000 2001, there was an increase in the international collaborations in the outbreak response. But basically, this brought in so many international partners to come and collaborate with Uganda to ensure that should such outbreaks happen, there's always something that can be done to control this virus, to prevent it from spreading to many, many other countries. So this outbreak began in Mubende, and it spread to quite a number of other regions. Definitely, there were challenges that were faced at the time, including the fact that there were no licensed vaccines initially for this Sudan Ebola virus. Okay, as of now, we have heard that there are some vaccines that have come up, though we're not yet sure if most of these vaccines are approved for Sudan Ebola virus. But at the time, just know we didn't have vaccines. As of today, many vaccines have come on board, okay, and we believe many others are going to come through research, and some of these could help in the control of some of these transmissions, as well as the urban transmission risk. So somebody could get the Ebola from the forest or deep rural areas, and as they move from their places to come maybe in the central, they could actually bring in these Ebola viruses, spread it to people in the communities of towns or urban communities, and definitely that's such a huge challenge. Also, at the time, there are Can you hear me now? Sorry, I had a bit of a glitch in the internet, but I hope you can hear me. I once again tell you that my name is Dr. Sech. Hello. So yes, I hope you continue to hear us. I hope I can be heard now. Yes. So again, I tell you that my name is Dr. Sechanzi Henry, and I continue to take you through this our episode of Ebola. We understand that we just had a session led by our experts from the Ministry of Health, who took us through the fundamentals of Ebola, and I'm here to take us through the very, very final minutes, and we are about to conclude. So, I was just telling you that yes, Ebola is here with us. Some cases have been confirmed in Congo, and as of now, Uganda has also confirmed the case, and continue to work out mechanisms on ensuring that we don't have this virus continue to spread to our public. I've told you about the importance of isolating people that have Ebola, as well as ensuring that you have safe burial practices, in that if somebody dies of Ebola, I understand that here in Africa we are very, very communal beings. If somebody dies, we always want to attend the burials, be there for them and their families, but man, Ebola is something else. It's something that the moment it happens, you don't really have to go and be there, because it could get from that person who passed on or from their relatives onto you. So we always have to take as much caution as possible to ensure that we don't spread this virus to other people. So you have to practice safe, as in safe burial practices, to ensure that this virus doesn't spread to us. Public health education. We need our public to know and understand what needs to be done to ensure that this virus does not spread. Or if we see somebody who is a suspected patient of Ebola, they need to know what to do should such things happen. Border surveillance, Uganda, Congo, Rwanda, Burundi. Now that we've heard that some cases have been confirmed in Congo, there has to be a lot of surveillance between the Uganda and Congo border to ensure that in cases are not transported or imported from Congo to Uganda. Because should cases be transported, they could come into the country to levels that they are very, very overwhelming, and it's very difficult to control these cases. So there has to be efforts to ensure that these cases are not transported into the country. All this said, Uganda has declared an outbreak. So we've all seen the news that Uganda declared an outbreak of Ebola virus, and this followed a case that was from Congo, where somebody was managed in Chibuli hospital, and this person unfortunately passed on. But upon passing on and on doing thorough evaluation, it was discovered that this person had Ebola. Okay, so we have to take all the precautions possible to ensure that this virus does not continue to spread to other people. Why Uganda became important in Ebola research? You understand that Uganda, my motherland, a very beautiful country, is such a beauty, not only physically in terms of geographical features, but also in academia. We have so many institutions like Makerere University, Gulu, Sitema, KIU, as only to mention but a few that are involved in research. And also when this Ebola outbreak happened, there has been so much research going on to ensure that we get to the core of this Ebola, manage it, find out the vaccines, find out the best treatment, ensure that you have adequate surveillance to control this virus. In this regard, there have been a number of surveillance and a number of efforts to ensure that this virus is contained. So Uganda has already employed very strong virus surveillance techniques to contain the virus, as well as outbreak containment strategies that are already in place. We already have a number of vaccine trials that are aimed at ensuring that we get the effective vaccines that can be used by our public to ensure that we control this virus, as well as community-based controls. Okay? We're trying to teach our public so that they know what to do should they suspect anybody in their vicinity to be having Ebola virus. Likewise, the number of rapid response systems that have been developed. I understand that you have what you call an African Center for Disease Control, African CDC, of which I think this idea was copied from our counterparts, the Americans, who have an American CDC. So there's definitely a lot that can be done in terms of rapid response to ensure that our populations continue to remain safe from Ebola virus. And definitely a number of other rapid response systems. So we established a surveillance system that is going to track any cases of Ebola and initiate the appropriate interventions to control the disease. Institutions like Ebola and the Uganda Virus Research Institute are continuing to play a huge role in the containment of Ebola, and quite a number of research strategies, not only about the diagnosis, but also for treatment of Ebola. Now, another important issue that comes up is how this Ebola, we've seen the historical perspective, okay? So how important is this historical perspective, okay? And that's a point that I want us to really dig deeper into. So, historical importance of Ebola in Africa. Ebola is not a new thing. It has been here with us, and probably it will continue to be with us. Because like you've seen, most of the cases have been imported from places like the forests. Some of these chimpanzees, the monkeys, those organisms, they could have Ebola. Somebody could go there to visit them. They get in touch with these agents, and in a way, they pick the virus from there. When they pick the virus, they can transmit this virus to humans who didn't go with them to those places, and the virus could spread through such mechanisms. So, Ebola outbreak continues to be there in Africa and in Uganda, and this has transformed public health systems in Africa by improving the following. One, is better emergency preparedness. Today, our response to epidemics is not as it used to be back in the days when we didn't know about Ebola. There's so much that has happened simply because our emergency preparedness has greatly improved. That aside, our prevention and control of epidemics has greatly improved. And you can bear with me witness that when COVID-19 came, Uganda was one of the countries that greatly responded immediately to this pandemic, and we were able to contain it simply because, well, we've had the lessons we've learned from the previous outbreaks, and we were able to implement what we learned back then. Our laboratory capacity has improved. As of now, we are able to do rapid diagnostic tests. We're able to do polymerase chain reactions. We can do cytogenetics, molecular studies, PCR, polymerase chain reaction. And with this, we can be able to detect these Ebola viruses in a minute and push the necessary precautions into place to ensure that this virus does not spread far and wide to our populations. International disease surveillance has also improved, as you all understand that these days we live in a global village. If an issue happens in Uganda today and nothing is done about it, it could spread to any other parts of the country. Okay? If I have Ebola today and I'm going to travel to the USA, I could take Ebola to the United States of America. So, because of this, there are quite a number of international disease surveillance that have come in place to ensure that we control most of these pandemics that are happening in these countries. That said, vaccines and therapeutic developments, there are so many vaccines that are in development and those that have been rolled out there already to ensure that they control this pandemic, this problem of Ebola virus. We've recently heard that Rwanda has already implemented some vaccines to control Ebola virus, and many other vaccines are coming on board. So we believe with more research, with more science, with many government efforts,